in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers, like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, we at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, we at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to strong, constantly questioning. Are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning. Are we curious enough? Could we be closer? Can we? Can you feel it?
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, we at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, we at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle, a clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers, like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, We at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers, like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, we at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body.
Welcome to esteemed guest. It was the great pleasure we have with us, and after a long time we are doing a big cardio summit in Hyderabad. So thank you for your presence, doctors. So with this, on this auspicious occasion, we start our day with light lampening. So I would like to welcome our faculty members and chairperson, Dr. Daya Sagarao sir, and Dr. Srinivas Rao sir, and Pramod Kumar sir, and Nirmal Kumar, and we have Merck National Sales Manager Tony George to come and start with the light lampening. Thank you so much, sir. So, welcome once again, doctors. So, with this, now we are going to take our Merck corporate deck for next 5 minutes. So, thank you for your presence, doctor. Welcome to 22nd June 24 CP Summit Cardio Protect Summit. So, sir, Merck, the global leader, innovators of bisoprolol, pays tribute to Sir James Black on his 100th birth anniversary. Sir, in this honor, contribution towards the discovery of beta blockers, which is happened on 1924. In the celebration of Sir James Black on his birthday, we at Merck, the innovators of bisoprolol. With this, the world of conquer the world of categories into passion, dedication, wisdom, and love, all encapsulated in a small pill that embodies the manufacturing of excellence since 1986. With this, 38 years of journey of bisoprolol in Merck. So the first beta blocker globally, and now we are the #1 beta blocker brand in India. With this, from the world of Concord, we welcome you all for the today's Cardio Protect Summit. So taking for it next your 2 to 3 minutes of time, who we are. So we are vibrant science and technology company. Science is heart of everything we do. So we are Merck. Every day, nearly almost 56,000 employees work in 66 countries to make a positive difference and millions of people's lives by creating more journey peaceful. And patients are the center of our work. Our portfolio addresses the therapeutic areas, oncology and immuno-oncology, general medicine and endocrinology, neurology and immunology, and fertility. Every day, more than 72 million patients across worldwide by using our medications. We are very youngest organization, nearly 355 years of experience for patients and customers. The evolution of Merck India Biopharma, it is 50 years of history. And our Merck India Biopharma is categorized into the divisions CM Care, that is cardiometabolic care, with a flagship brands of Concor, Concor AM, and we have a innovator brands of Carbofez, Etharox and Starvogue, Lipigo, Almighty and Lodos. Moving forward from the heart, we welcome you all to the world of Concor. Concor, the innovator bisoprolol brand, is marketed in 117 countries and taken every day by more than 20 million patients across worldwide. We would like to express our gratitude for your support and guidance from all these years. So, number one beta blocker brand in India is Concor, with the highest consolidation of units to BB market, and Concor is prescribed by every third patient of beta blockers. And we have, from last 2 years, we have overtaken the Nebivolol, and bisoprolol came in the second position. And with the doctor's approach, we got the few suggestions from few set of doctors. Telmisartan and beta blocker, that is bisoprolol, is having the highest market share. With this, we have introduced our brand, joining the hands, the world's number one beta blocker and India's first ARB, that is Concor and Telmisartan, join hands together to provide a comprehensive neuroendocrine blockade, which is presenting Concor T, which is Telmisartan with bisoprolol, offers comprehensive neuroendocrine blockade. After launching of Concor T, our Concor portfolio looks like Concor and Concor Core, Concor AM and Concor T. With this, I would like to welcome our ZBM Zonal Sales Manager Manohar to introduce our today's chairperson and faculty members.
So good evening to all. On behalf of Merck, once again I welcome you all for today's Cardio Protection Summit. For this today we have with us all eminent speakers and chairperson for today's event. And firstly I would like to introduce Professor Dayasagar Rao sir as having more than 40 years of experience in the field of cardiology and having enormous knowledge in the field of cardiology. And I welcome you sir for today's meeting as chairing the session. And with this, sir is giving an overview of beta blockers and setting the context for the day. And next speaker with us, we have Honorable M. Srinivas Rao sir as HOD and is a HOD of cardiology in Apollo Hospital. Sir is having more than 25 years of experience in the management interventional cardiology. And today sir is taking about how beta blockers will be, latest things in the management of CAD heart failure. And with us, welcome you sir once again for today's meeting. And with us we have one more eminent faculty today is Dr. Pramod Kumar sir. Will take you through all the survival in the management of CAD. And welcome you sir for today's meeting. And we have with us Dr. Nirmal Kumar sir will be taking the resurgence of beta blocker in the management of hypertension. So sir is a senior in International College at Century Hospital, Hyderabad. So with this small introduction, I welcome Professor Dayasagar Rao sir setting the context for today's meeting as well. So welcome you sir for you. Thank you sir. Thank you.
I think we're already late, but I think just a short history of beta blockers and their usage in clinical medicine and how a contraindication became an indication. So I think probably now the first beta blocker was propranolol that was clinically used. And if you recall, the first paper to use a beta blocker in hypertrophic obstructive cardiomyopathy was at Hammersmith Hospital, and the authors of the paper are Dr. George Cherian and John Goodwin and Praveen Shah. That is the effect of beta blockers in the symptom relief of hypertrophic obstructive cardiomyopathy. We have come a long way from that, and then we went through hypertension indication, then we went through arrhythmias, we went through coronary artery disease, and congestive heart failure at one time, it was contraindicated, beta blockers. At that point of time, it was felt that inotropic reserve and inotropic power should be preserved, and usage of beta blockers is going to nullify that. Then subsequently came the data, analysis of the data, which showed that the progression of the heart failure is influenced by sympathetic activity. So the greater the sympathetic activity, the worse is the progression, and the progression means worsening prognosis. So from that end of where beta blockers were contraindicated, it became the class 1 indication for heart failure. So same thing can be said about hypertension. The paper by Dr. Sripal Bengaluru, who said beta blockers should not be given in treatment of hypertension because they have got some adverse hemodynamic effects, like the central aortic pressure does not decrease. But then it was that the beta blocker that they chose to evaluate was atenolol. And now, whenever we talk about beta blockers anywhere in the world, the first thing is atenolol. But I think it is important to understand that beta blockers are not the same. All beta blockers are not the same. Each one has got a special niche to be used in those particular patients. And we have now enough data saying that beta blockers should be given to patients in heart failure after they have become totally dry. That means there is no waterlogging of the patient, no edema of the feet, no congestion in the lungs, and no contraindications for usage of beta blockers like bradycardia, conduction disturbances, and obstructive airway disease. So we are not sure what is going to happen next. Actually, it is often forgotten that beta blockers in combination with alpha blockers is the treatment of choice for the management of pheochromocytoma with severe hypertension. But beta blockers alone should not be used in pheochromocytoma. If we use beta blockers alone, the hypertension is going to worsen. So much so that it is said that if you are giving beta blockers and the hypertension is becoming worse, think of the possibility of a pheochromocytoma, because unopposed alpha action. That is the reason why probably we should be careful before we give it. I have a lot of discussion about the role of beta blockers and erectile dysfunction, whether to be given in younger patients, whether to be discarded. There is controversial data, but by and large now, erectile dysfunction is probably one of the fewer side effects and not so common, at least with the bisoprolol. So to tell us more about the usage of beta blockers in various conditions, the first speaker is going to be Dr. Nirmal Kumar. He is going to tell us about usage of beta blockers in hypertension. Dr. Nirmal.
Good evening, chairpersons and speakers, ladies and gentlemen, and thanks to Merck for giving me this opportunity. I'm not a very good speaker, but because of the request of the Merck, I have these things. But I will try to justify my presentation. And sir has already simply explained about the beta blocker in hypertension. If you see the beta blocker, one of the mainstay of the treatment for the hypertension for long years till the trials like Escorts and Life came, and they have shown the adverse effect with the beta blockers, and this is not very efficacious, and there is a increased risk of stroke with the beta blockers. But if you see this, all these trials, they have used the atenolol, and atenolol is a short-acting beta blocker. The half-life is only 6 hours. And there is it doesn't control the early morning surge of the blood pressure, which is the main cause of strokes. So with the development of the new beta blockers, especially the bisoprolol, like which has a 24 hours control of the blood pressure, number one thing, and it is the beta blocker which work on the central aortic blood pressure. That is the and because of the 24 hours action, central aortic blood pressure affects the bisoprolol we can be used uh, as a monotherapy or as an add-on therapy to the uh, add-on therapy for the hypertension. So if you see the hypertension disease burden in India is high, almost we are expecting 215 million patients will be in hypertension by 2025, and 29.8% there is a prevalence of hypertension in India, and every year 3.5 million people died because of the cardiovascular disease. And the studies, Indian studies, they have shown there is a poor hypertension control rates in India. Almost 77.5% of hypertensive patients don't have their blood pressure under control, and only 50% of the patient in 15 to 49 years of age knew their hypertensive status. And another issue that everybody knows, the cardiovascular event related death occur almost a decade earlier than the developed countries, and cardiovascular event rate is almost double, 52% as comparison to 23% in the Western countries. And we have found that there is a high prevalence of hypertension in the young adults, especially 20 to 44 years, and 62% of the newly diagnosed hypertensive patients in India have a sympathetic overdrive, and more than 50% of the patients have a high heart rate. So the Indian Heart Study has shown the mean age of hypertension is less than 45 years, and the heart rate is more than 80 per minute. So why the heart rate is more important? Because now it's considered as another predictable risk factor for the adverse cardiovascular event. If you see the Frenchman studies, as the heart rate goes above 80, there is an increased risk of cardiovascular events. And if you see this study, even with the good blood pressure control, even with the well-controlled blood pressure, there is a 53% difference in the incidence of endpoints between the low heart rate and high heart rate. And if you see the value studies, they also found that the increased heart rate is itself is one of the predictor of adverse cardiovascular event. So as we know, all the guidelines they have suggested, except in the young mild hypertensive patients or very elderly frail patient, most of the patients requires 2 or more than 2 drugs. And all the major guidelines, they have suggested a combination therapy to improve the speed, predictability and efficiency of the blood control. So combination single pill is always better than you give the 2 or 3 pills. And whenever the patient has a blood pressure more than 20 by 10 millimeter above the target goal, you require at least 2 antihypertensive drugs. So till 2023, even in the 2018 guidelines of European Society of Hypertension, the beta blocker was not in the main 5 drugs class of the hypertension. But 2023, the European Society of Hypertension has recommended the beta blocker can be used as a monotherapy or any step of a combination therapy. So now the next slides I'll explain. And we know the beta blocker, some indication of the beta blocker is class 1A, some are 1C. As we know, the beta blocker is the mainstay of the treatment, hypertension associated with the coronary artery disease, all spectrum of a coronary artery disease, unstable angina, acute coronary syndrome, acute MI patient, because it reduces the arrhythmia, reduces the heart failure, and post-MI angina, and Also, the beta blocker is indicated in the heart failure patients. 1 minute. And all the patient, as the sir has told, that all the patients with the heart failure with reduced ejection fraction, beta blocker is one of the mainstay treatment in the guideline-directed medical therapy. Then heart failure with preserved ejection fraction also, if it is associated with the ischemia, arrhythmia or tachycardia, atrial fibrillation, and all hypertensive disorders in the pregnancy, the beta blocker is the mainstay of the treatment. Some other indication where the beta blocker can be favorable, we can combine the beta blocker with other antihypertensive drug, like if the patient has an elevated heart rate more than 80 beats per minute, all the emergency, urgency and parenteral administration, like we are using the labetalol in hypertensive emergency, perioperative hypertension. Then the patient who has a POTS syndrome or thyrotoxicosis, migraine and essential tremors, propranolol does very good. Performance anxiety and anxiety disorders, most of the students sometimes take the beta blocker, propranolol, before going for examination and interview. So why the 2023 European Society of Guideline included the beta blockers as one of the monotherapy or combination therapy? Because we know that the increased resting heart rate more than 80 per minute is a common in hypertension. I have shown in Indian studies, 62% of the patient, they have a high heart rate, and which reflects increased sympathetic activity. And this heart rate increases the risk of atrial fibrillation, heart failure and mortality both in the general population and hypertensive patient. So thus the available evidence make the hypertension patient with increased heart rate a clinical phenotype supporting the use of a beta blocker. The characteristic of hypertension and cardiovascular disease in Asia is that the more risk of a stroke, almost 2.8, and non-ischemic heart failure, they are more common than the myocardial infarction. And there is a steeper association with the blood pressure and cardiovascular disease, high salt intake and high salt sensitivity. Obesity and metabolic syndromes are epidemic in Asian population, especially Indian population. They have a more morning hypertension and nocturnal hypertensions are more common. So that's why in the Indian population, now the blood pressure target goal is 130 by 80 rather than 140 by 90 because of so many risks. And Indian population also, they have a increased sympathetic overactivity. This is trial has been done by Dr. Padmanabhan, very well-known cardiologist in Hyderabad, and almost 62.42% of the patient, Indian patient, they have a sympathetic overactivity. And they found that there is a high renin levels in the Indian population also. So they have a sympathetic overactivity as well as a high renin levels. So the Indian population, they are the non-dippers, means there is a no decrease in the blood pressure in the night. They have a OSA having a high heart resting rate, high renin level. There is a early onset of hypertension, and there is a significant seasonal variation of the blood pressure also. So Indian hypertension patients are overactive. They are sympathetically overactive. So there is a need of a comprehensive neuroendocrine blockade in Indian hypertension, because they are SNS system and neuro, because they have a high heart rate and there is a high renin level. So this is that's why the concept of the combination of the bisoprolol, which is a highly selective beta blocker, and telmisartan came. Usually all over the world, if you see, the best combination is the perindopril and bisoprolol, because perindopril is also 24 hours acting drugs and bisoprolol is also a 24-hour acting drug. But there is some patients who have a more problem with the perindopril, especially the cough and intolerance. So that's why this concept is the came when you combine the telmisartan with the beta blockers. The observed greater blood pressure lowering effect of the beta blocker add on to the combination of ACE inhibitors and ARB is noteworthy. Such a combination is not recommended by any current hypertensive guidelines because a beta blocker suppress the renin secretion and reduce the plasma renin level of angiotensin 2 and therefore perceived to be less additive in antihypertensive efficacy to the ACE inhibitors or ARB. But the additive effect of the beta blocker add-on to ACE inhibitor and ARBs on the blood pressure reduction was indeed less than that of the diuretics and calcium channel blocker. The effect is much less, but even to 2 to 4 millimeter greater reduction of the blood pressure is appreciable. And combination of the ACE inhibitor ARB with the beta blocker is recommended as the first line therapy in the patient with heart failure or myocardial infarction. And the recommendation, this recommendation not solely based on the blood pressure lowering effect, but rather than a cardioprotective effect. So when you combine the beta blocker with ACE inhibitors or ARB, not mainly for the controlling the blood pressure, but at the same time the beta blockers has a cardioprotective effect. If you see the two neurohumoral mechanisms, one is the sympathetic nervous system and another is the RAS system, which is a important risk factor for the cardiovascular disease continuum. So if any, so whenever you combine the ACE inhibitor ARB with the beta blockers, you usually break the positive feedback loop between the SNS and RAS system, because if you see the sympathetic nervous system activation leads to the increased renin secretion from the juxtaglomerular cells, and thereby it activates the RAS system, and RAS system further activate the SNS system by increasing the noradrenaline release. This is called the positive feedback, and this combination, when you combine the bisoprolol with RAS inhibitors, they break the positive feedback loop between the SNS and RAS systems, thus they have a cardioprotective effect. It prevents the reactive renin upregulation and offers a comprehensive neuroendocrine blockage. Even in the Indian consensus also is towards the utilization of this combination bisoprolol and telmisartan. They consider it as useful in patients with the comorbidities and is an expanding therapeutic armamentarium to address the unmet medical need in hypertension. So you can use this combination in stage 2 NAV hypertension patient with a high heart rate. When the heart rate is more than 80 per minute, you can use in the patients with a compelling indication like a coronary artery disease and heart failure and atrial fibrillation, young and a middle-aged group, and hypertension with the CKD up to the stage 3. Even in the hypertension with the metabolic syndrome patient, the beta blockers, when you combine the beta blocker with the telmisartan, it reduces the ventricular arrhythmia, also have a protective effect from the beta 1 stimulation induced cardiac and coronary artery damage, is also helpful in a non-dipping blood pressure in the night, and same time is also have a protective effect on nephropathy. Another good combination is the bisoprolol with amlodipine, like a Concor AM we are using for a long time. So what is the rationale of these two drugs? When you combine the bisoprolol with amlodipine, both bisoprolol target the sympathetic nervous system on the heart and RAS system in the kidney. Thereby inhibition, it inhibits the SNS system as well as the reduction of a renin activity. Same time, the calcium channel blocker amlodipine reduces the it causes the smooth muscle relaxation, vasodilatation. All these mechanisms lead to the reduction in the BP blood pressure, which has a good cardioprotective effect. So there is a significant reduction in the both systolic blood pressure and diastolic blood pressure compared with the baseline, and this combination improves the aortic blood pressure and variability, magnitude and speed of the rise of the blood pressure in the morning, and you can see the effect as early as possible, as early as in the 2 weeks. Heart rate was slowed significantly. there is an improvement in the pulse pressure and pulse wave velocity versus baseline, because these are the indicator for the arterial stiffness. So they reduces the arterial stiffness and they are cardioprotective and excellent adherence. These are the various non-investigational studies, 10,000 patients, and with multiple comorbidity. They are a diabetic, hypertensive, smoker, alcoholic, and has a cardiovascular disease. These are 12,000 patients. These are the 4,288 patients, and another is 758%. But all these studies, they have found that there is a good adherence with the fixed dose combination of a bisoprolol of amlodipine. Almost 98% of the patient has a good adherence. There is significant decrease in the blood systolic as well as the diastolic blood pressure as well as the pulse pressure, and the heart rate decreased by a mean of 5.6 beats per minute, and there is no effect on the lungs function, and there is a good vasoprotective effects, and there is a significant reduction in the ischemic symptoms. To summarize my presentation, the new 2023 guidelines from the European Society of Hypertension includes the beta blocker within the 5 main classes of hypertensive agents, suitable for initiation of antihypertensive pharmacotherapy and for combination with other antihypertensive agents. In contrast to 2018 guidelines that recommend the beta blockers for use primarily in the patient with a compelling indication such as a cardiovascular comorbidity, example coronary artery disease and heart failure. This change was based on the fact that the magnitude of a BP reduction is the most important factor for adverse cardiovascular outcome, over and above the precise manner in which the blood pressure is achieved. Beta blocker excluding atenolol as a add-on a several other class of antihypertensive drugs such as a diuretic, calcium channel blocker, ACE inhibitor, ARBs were efficacious in further lowering the blood pressure. Combination therapy with the beta blocker is as effective as non-beta blocker combination therapy in trials. In line with the current guidelines recommendation, beta blocker can and should be used in combination with other classes of antihypertensive drugs at any stage of a treatment. European Society of Hypertension guidelines also support the use of a beta blocker for the patient with resting heart rate more than 80 beats per minute, because the high resting heart rate is a sign of a sympathetic overactivity, which is an important driver of adverse cardiovascular remodeling in setting of hypertension and heart failure. It also supports the use of a combination of therapy for almost all patients with hypertension, ideally with a single pill combination to optimize the adherence and efficacy. Wherever the beta blocker is prescribed, the inclusion of a dihydropyridine calcium channel blocker within a combination regime is rational. These agents together reduce both peripheral and central blood pressure, which epidemiological studies have shown is important for reducing the burden of premature morbidity and mortality associated with uncontrolled hypertension, especially stroke. Thank you.
The next talk is by Dr. Pramod. He's going to talk about coronary artery disease and beta blockers.
Forward.
This is forward, this is backward.
Okay. Thank you. Respected Chairperson, Dr. Dayasagarov, the most reputed cardiologist of our era, and distinguished delegates and my co-speakers. Nirmal has described nicely the physiology and the indications
and more importantly, he has highlighted certain aspects of Indian hypertensives who have high resting heart rate. That is one of the important usages where the beta blockers are useful. And also he highlighted the rationale behind the combinations of adding telmisartan or amlodipine to the beta blocker, that is bisoprolol. So we have a lot of experience of using beta blockers. Time and again, we discuss about beta blockers, the demerits, and then de-prescription. That is a new term that is coming up. Whether it is valid or not, we have to analyze. And the more important problem about the beta blocker was the de-prescription of atenolol. That has hit a problem to the beta blocker saga. And the trial that was quoted was the old trials with the atenolol. And what Deholf, he is the person who claimed that atenolol is bad because it increases the risk of strokes. And thereafter there was a setback for the beta blockers, but again there are many uses, and especially now in heart failure, beta blocker has become one of the important components, one of the 4 pillars of the heart failure management. So Nirmal has given all the indications where the beta blockers are used, but I think predominantly beta blockers are useful in hypertension, as he already mentioned. Second is coronary artery disease, and third is heart failure, which Dr. Srinivas is going to talk. So my talk is about bisoprolol in coronary artery disease, mounting evidence and benefits. So this is some epidemiology about the coronary artery disease in India. As we say that we are a developing country, we experience some of the non-communicable diseases. Most importantly, the coronary artery disease and malignancies, they are increasing. We no longer see the old diseases like leprosy or other infective diseases. Now, if you look at the statistics, the global burden is increasing, especially in our country. CHD has caused highest deaths, almost 20% in India in 2016, according to some data, and showed an escalating trend with almost 50% increase between 2007 and 17. This may be attributed to the change in lifestyle which we are experiencing. That may be one of the explanations which we give why the disease is increasing. Also the urbanization, recently the pollution and all other things are adding to the increased incidence of coronary artery disease in India. And if you look at the trends in ischemic heart disease mortality in the most topmost 5 countries, India and China, as you know, are the leaders in population, and we see the IHD numbers are also higher in these 2 countries, whether it is absolute numbers or when you look at the comparative numbers as well. So you can see we are almost on the top of this graph, IHD deaths due to absolute numbers. That only gives us an idea that we should be more aware of early detection of the disease and also primary prevention or primordial prevention. These are the important messages which we have to take when we look at the slides like this, which show that we are on top of the disease charts. And one more important thing is our Indian population has certain specific characteristics with regards to the coronary artery disease. We developed the coronary artery disease almost a decade or a decade and a half younger when compared to the European counterparts. So we see patients, nowadays we see patients who are coming with acute MI, atherosclerotic disease, 20, 22 years also. So again we go back to the same thing, lifestyle modification. I always say that we are not able to identify because we are not emphasizing on the screening procedures. So sometimes people say we are seeing more and more cases nowadays. That is because we are able to screen the people and then pick up the risk factors. I think this trend should increase more so that we can at least prevent the major fatalities in this younger population. And second, there is an increase in the multivessel disease in our population. We see people with multivessel disease and they require multiple stents, and they also require repeated procedures because there is a comorbidity. Diabetes also, which is increasing. We are diabetes capital of the world, as everybody knows. And we also have a diffuse disease. Maybe because high incidence of diabetes, the vessel caliber is very small. Diffuse means the entire vessel is layered with cholesterol plaques. And then when we try to stent it, we have to look at a spot where we have to stent. And sometimes people go for surgery, or sometimes there is no option for these patients because they are so thin that a surgeon cannot graft and I cannot put a stent. So they will be on medical therapy finally. And there is a distal disease as well, which precludes them from going for a bypass surgery, because when a bypass surgery is done, the surgeon will graft it at the distal part. If the distal part is too thin, they are not suitable for bypass surgery. And there is also a significant left ventricular dysfunction, and presentation to the hospital is late. Even in acute also, there is a data from Trivandrum and Kerala registries. The average time of presentation with acute MI is 6 hours. So that is not a good trend. Of course, now the trends are changing because awareness is increasing. So these things need to be educated to the physicians and also general cardiologists, because early diagnosis is very important. So it is, as I mentioned, due to increased incidence of diabetes, smoking, hypertension, sedentary lifestyle, abdominal obesity, unhealthy diet, and dyslipidemia in younger age, both genders, men and women. And there is also a term called malignant coronary artery disease in young Indians. This is done by Enos and Enos, who is a pioneer in this particular thing. He has devised a study called CADI study, coronary artery disease in Indians. But these are the Indians who migrated. And in those migrant Indians, the coronary artery disease was 6 times more, because there is a adoption to the new environment. That is what he postulated. But they have a atherogenic dyslipidemia, a difficult pattern of dyslipidemia to manage, and they are very premature, extreme severity as I mentioned, and there is a high mortality at younger age in this group of people. And when we look at the goals of medical therapy in these patients, the most important thing is to reduce the frequency and severity of angina. That is symptomatic relief. That is the most important thing for a patient. And second, to reduce the future cardiovascular events. So coronary artery disease is progressive. Initially, the patient may have a mild plaque, but it keeps on progressing. And then sometimes it may abruptly increase by way of a plaque rupture and present as acute coronary syndrome, either a myocardial infarction or an unstable angina. So these events should also be prevented because they lead to hospitalization. And second, as a consequence of these myocardial infarction or because of diffuse disease, a chronic ischemia to the ventricle leads to ventricular dilatation, and the patient may go in for a heart failure. And with a heart failure, again, the problems of arrhythmias, then hospitalizations, all these things will increase. So if you are looking at the goals of treatment in a patient with coronary artery disease, there are 3 important things. One is symptomatic relief, second is to prevent the events, and third is to prevent progression to the heart failure, and fourth important thing is to prolong the survival. So that is the main goal, and I think this drug, beta blocker as a group, along with others, newer drugs that came in, fulfills these particular objectives. Now, if you look at the beta blockers in coronary artery disease, it can be used in all kinds of coronary artery disease. So there is a spectrum when we talk about coronary artery disease. It's a stable angina, we call it. There are asymptomatic people also, or people who present with acute coronary syndromes, or people who present with heart failure, terminal heart failure, or end-stage heart disease we call. So this is a big continuous spectrum, and it is also called cardiovascular continuum. That is the term coined by Braunwald, and we have to use these drugs at every step. So it is like a cycle. It goes from asymptomatic, then coronary artery disease, progression, myocardial infarction, events of myocardial infarction, then cardiac dilatation, heart failure, end-stage heart failure, and finally death. So to complete the cycle, if we believe in the rebirth, so that will be again starting in the next life. So appropriate use has led to increased survival and improved quality of life in the patients with coronary artery disease, and because there are several beta blockers along with other drugs, they are going to help us in combating these things. I think this slide again mentions what all the spectrum of coronary artery disease: stable angina, unstable angina, myocardial infarction, heart failure. That is the continuum we can call. And when you look at the CCS, we call it nowadays, we call it a chronic coronary syndrome. There is a goals of treatment. Again, we are coming to the same point. initially the symptoms and functional limitation, then arresting the disease progression may not be completely possible, but at least we can retard the progression and delay the consequences, non-fatal ischemic events, and finally cardiac death, we are going to decrease them. And the dose of beta blockers should be adjusted to limit the heart rate. Nirmal has talked about the heart rate. There are very interesting information about the heart rate. Increased heart rate is directly proportional to decreased lifespan. So if you look at one of the smallest mammals called shrews, the heart rate unbelievably is 1,000 beats per minute. And the lifespan is only 1 year. It is a mammal. And if you look at the blue whales, the heart rate is 2 beats per minute. And some of the turtles, sea turtles, their heart rate is very low, like 6 beats per minute. And they live longer. They live 200 years, 300 years. So probably in our ancient Indian culture, the yoga are able to control the heart rate by decreasing the sympathetic activity. People were living longer. So maybe our sages lived 100 or 200. We have to believe when you apply this logic. So that is one of the important areas where beta blocker helps. And we also know that in patients with heart failure, if you control the heart rate to a 60 or 65, of course there are other drugs also which are specifically designed to decrease the heart rate, their survival was increased. And some computations have been made where if you decrease the heart rate by 10 beats per minute over a period of time, the lifespan is increasing by 10 years if you apply the logic. So this is epidemiological data which again shows that it is very important, and Nirmal has also already mentioned the average Indian heart rate is 80 or more because of increased sympathetic activity. So there is a definite role to control the heart rate by use of these drugs. And second, when we are trying to discontinue the drugs, we have to be very careful, especially with the beta blockers. Many times what happens, the patient goes from doctor to doctor, and commonest thing we see is the old prescriptions of atenolol. Still we see, somebody sees, a young cardiologist may look at it and will say, oh, this is a very old drug, stop it from tomorrow. And the same evening the patient will come back to any other hospital with an increased heart rate. So there is a rebound increase in heart rate if you suddenly stop the beta blockers. This is one of the important things you have to remember when you are trying to change the prescription which is already there, very specifically with the beta blockers. So never just abruptly ask the patient to stop the beta blocker, especially if the patient is going for any surgery. If you stop the beta blocker abruptly, the surgeon will have a problem, anesthetist will have a problem, the patient of course will have a problem because there is a rebound tachycardia in these people. This is one of the important point to remember. And it can be combined with other drugs like dihydropyridine calcium blockers to reduce the DHP-induced tachycardia. Especially still we see some people using nifedipine or amlodipine, for example. They can increase the heart rate. And if you combine with a beta blocker, that at least attenuates the increased heart rate. And caution is warranted when beta blocker is combined with verapamil or dilsam. So among the calcium channel blockers, these are called non-dihydropyridine calcium channel blockers, verapamil and diltiazem. They have a tendency to lower the heart rate. So if you are adding a beta blocker to these people, they may have a further lowering of heart rate, and it may lead to precipitation of heart failure, or it may lead to acute coronary syndromes also in some people. So this is another important point we have to remember when we are combining with non-DHP calcium channel blockers. And sometimes we see patients, especially in elderly people, they come with complete heart block because of the usage of the combination of these drugs. And then we stop these drugs, and then we see that it is reversed, or sometimes they may unmask the underlying sick sinus syndrome, and we may end up putting a pacemaker for those people. And when we combine it with the nitrates are usually given for coronary syndrome patients, and it attenuates again the reflex tachycardia. So as I mentioned, if the heart rate is more, the myocardial oxygen demand is more, and therefore reduction of heart rate is beneficial in coronary artery disease. And this is the guidelines which recommend usage of beta blocker as a class 1 for hypertension, and also in patients with symptomatic angina, there is a role for beta blockers and also calcium channel blockers, but it is very important to remember this particular point. So guidelines have approved this, there is approved indication. And if you look at the recent publications of American Heart Association guidelines, there is a class 1 indication if the patient's left ventricular ejection fraction is less than 40% with or without prior myocardial infarction, then beta blocker is recommended. And if the patient's ejection fraction is more than 50%, the use of sustained release metoprolol, carvedilol or bisoprolol to titrate to the target doses is recommended over the other beta blockers in people who have LV dysfunction. So we are talking about these two groups are people who have LV dysfunction, meaning ejection fraction is less than 50%. And if on beta blocker therapy without any history of myocardial infarction, with or without a history of low ejection fraction, angina, arrhythmia or uncontrolled hypertension, then it becomes a class 2B indication. And lastly, we have if there is no previous myocardial infarction and the ejection fraction is less than 50, then it is a class 3. There is no benefit. So the summary of the slide is if the patient has LV dysfunction, definitely the beta blocker should be given. If the EF is less than 50, we have to consider this definitely. I think about the other things the next speaker will be mentioning. And what are the effects of beta blocker, how this is giving the salutary benefits in all these things. There are many theories and some of them have evidence from the bench studies, etc. So I think this slide we can skip because we are more focused on the practical application. Classification also I think we will skip because, but the highlight is here the beta selectivity is very important. That is for the bisoprolol, beta 1 selectivity. It is not non-selective, it is a selective beta blocker and does not have intrinsic sympathomimetic activity. That is one of the important things because if it has intrinsic sympathomimetic activity, it is going to increase the tachycardia, but this does not. The same group of drugs like metoprolol, bisoprolol, they are selective and they do not have ISA, we call it, and they control the heart rate. So according to geographical reason, you can see bisoprolol tops one of the list. It is called Zabesta in other countries. Here we call it a Concor. NICE guidelines are British guidelines. They also have an indication for bisoprolol. Can be used commonly after acute coronary syndrome. And there is a lot of literature because we are scientifically guided when we use the therapies. We have to also look at the papers that are published and the data that is available. So we can see there are many trials. Some of them are large trials, some of them are small in number, but there is a wealth of evidence as you can see there. And this is from Canada. There is a trial. They screened about 294,000 people and they looked at various aspects in these people over a period of 5.2 years and they divided them into new users of beta blocker and no users of beta blockers. So they divided the patient. Final numbers were around 25,000. And over 5 years, they were looked at. The objective was to determine the association between beta blockers and cardiovascular events in patients with stable coronary artery disease. This study actually is a study done in elderly people. The age group varied between 60 and 105. So that is also interesting to know because we are afraid to use beta blockers in elderly people. They have used in people up to 105 years in this particular study. And you can see bisoprolol was used maximum, 66% of the population. I mean more than 2/3 of this study cohort they have used. And what were the results? Results were primarily it was driven by reduction in the myocardial infarctions. That is one of the important things. Composite of death, hospitalization for heart failure and MI was less. 8% relative reduction in the hazards of primary outcome and absolute difference was 1.8. So definitely there was some benefit shown and you can see the p-value is 0.006. So that shows statistically it is significant in the group of beta blocker when compared to no beta blockers. And this slide shows the sub-analysis, different subgroups they have checked, gender, then age, less than 75, more than 75. As I mentioned, it included people up to 105, that is important, multivessel disease, left main, all those cases, PCI within 90 days. Among all the groups, it was found that beta blocker was beneficial when compared to no beta blocker group. So it is a significant number, 12,000 patients for 5 years follow-up is quite significant. Definitely it's a good study. And then if you look at the people with angina, largest and longest duration study is there up to 14 years, 7,000 patients. Objective was to evaluate the effects of bisoprolol on mortality and cardiovascular outcomes in patients after the first diagnosis of angina. So there they have divided into 3 groups: bisoprolol group, other beta blockers, and drugs other than beta blockers like CCBs, etc. And this is a long-term evaluation of bisoprolol in people with angina. And you can see the top blue line is bisoprolol. So bisoprolol has significant improvement in survival in patients with angina. So it is quite a long study. 14 years is again a big study. Definitely we have to take it as a good study. And significant longitudinal mortality reduction with bisoprolol in patients with angina, 55% lower risk of mortality compared to other beta blockers, and 50% lower risk compared to drugs other than beta blockers. So as I mentioned, those 3 groups were there. So bisoprolol compared to other beta blockers and other non-beta blockers. In all the cohorts, there was a benefit shown with the bisoprolol. It's again a robust data, we have to take it. And as I mentioned about the heart rate, this is what is called resting heart rate. RHR means resting heart rate. And you can see there the event rates are lower if the heart rate is less than 65. Resting heart rate less than 65, there was a significant benefit in this particular group. The event rates were 2.98 in people who had a resting heart rate less than 65. And people who had more than 75, the event rates were almost 3 times more. So therefore, the improved CV outcomes are observed if the heart rate is low. This is seen over a period of time. So if you continue to administer the beta blockers, the chronic beta blockade will attenuate the heart rate. And over a period of 18 months, if you can see, there is a sustained low heart rate in this particular group. BISOCAD is one of the often quoted studies. This is from the Southeast Asian countries. It is from China, South Korea, and Vietnam. Not huge number of patients, but they have seen in these patients association of different resting heart rates and composite cardiac events. Again and again, we are going back to the same point. If the heart rate is less than 65, the benefit is there in coronary artery disease and also heart failure. So please remember these 2 points. I think that is enough about this study from our Southeast Asian counterparts. Here also the same thing. The outcomes are better over a period of time, up to 1 to 1.5 years. And it also reduces the number of anginal attacks, just like CCBs, which are often given. The beta blockers are also indicated for angina treatment also. But we have to remember, as our chairperson has mentioned about pheochromocytoma, if the patient on beta blocker comes back with accelerated hypertension, so it is an unopposed alpha action that is causing high blood pressure. So we have to beware. And same thing with the coronaries also. If the patient has a precipitation of angina with a beta blocker, that means he is having vasospastic angina. Again, there is an unopposed alpha action which is producing vasoconstriction. So these 2 are parallel things, pheo and vasospastic angina. And definitely in other cases, the significantly decreased number of anginal episodes is seen with the bisoprolol. And it also improves the endothelial function. In the previous slide, I mentioned lot of beneficial effects, how this is bringing these changes. One of the things is endothelial function. We often talk about endothelial dysfunction that is going to cause atherosclerosis. Also, it causes proteinuria in the glomeruli, etc. So that is one of the early things which causes problems. It can be studied by way of brachial artery examination. The flow mediated dilatation can be assessed, and with the bisoprolol it was found that there is a benefit. So these are the statistics. And again, the guidelines 2023 were mentioned earlier also. Early initiation of beta blocker treatment is recommended in patients with ongoing ischemic symptoms and without any contraindications. It is recommended to continue chronic beta blocker therapy unless the patient is in KILIP class 3 or higher. That is applicable for acute MIs. I think these 2 important points are there in this. And the last point is again what I have mentioned. In patients with suspected or confirmed vasospastic angina, or called as Prinzmetal angina, CCB and nitrate should be considered, and we have to avoid beta blockers. So this is about the endothelial function I mentioned. And LVEF also there is a improvement. This is our own Indian study from Ahmedabad, 400 patients. They have given bisoprolol and compared to metoprolol, there was 66% improvement with bisoprolol. But I think we can accept this. At the end of 1 year, they have shown other drugs also might be contributing for this. And in STEMI patients, this is one of the interesting papers I came across. Generally, when we have a patient with acute myocardial infarction, we give beta blockers also. There are a lot of initial trials with metoprolol called ICIS studies. There it was recommended to give metoprolol IV. So I think we were postgraduates at the time. We were giving enthusiastically because the primary PTC and all these things were not there. So we were giving beta blockers. Subsequently, there was a data which said that people who receive beta blockers are going more into heart failure and cardiac shock. Mortalities are more. Then there was a setback. So these group of people, they have looked at an interesting aspect, when to administer the beta blocker. So they have divided the people into two groups. As soon as the diagnosis of acute myocardial infarction is made, within half an hour, they gave a low dose of beta blocker, 2.5 milligram of bisoprolol, and the other people were given up to 24 hours. So they divided these two groups. And in the ER, 2.5. Nowadays, we give clopidogrel, ecosprin, high dose statin, etc. Similar to that, 2.5 milligram of bisoprolol was administered in this particular study. 600 patients randomized in two groups, immediate beta blocker versus delayed beta blocker. And what they found is immediate beta blocker with a low dose bisoprolol in the emergency setting is associated with a reduction in all-cause cardiovascular mortality in patients with STEMI and seems to be superior to delayed beta blocker. This is one of the important things. What the authors mentioned is, if you delay the administration of beta blocker, the myocardial stunning and other things are more. The myocardial infarction will spread over a period of time. So if you are giving it early, it is helpful because it is containing the myocardial infarction, also reducing the arrhythmic burden, etc. So this is an interesting study. These are the statistics, the benefit what is shown in this. And early bisoprolol group showed significantly fewer ventricular arrhythmias, cardiac deaths, and MACE than the late group in non-STEMI also. Just like STEMI also, we see in non-ST elevation MI. On the ECG, if there is no ST elevation, we call it as a non-ST elevation MI, simple to understand. Here again, low dose beta blocker is helpful. 1.25 also is available to 2.5 is beneficial in these people. And in arrhythmias, definitely it is helpful. We all know that beta blockers decrease the arrhythmias and sudden cardiac death. There is a significant reduction in sudden cardiac death, almost 30% reduction. So this is very useful drug in people who have myocardial infarction and post-MI setting. Definitely it is one of the drugs to be considered. There is no second thought about it. It is useful in supraventricular arrhythmias also to control, or in people with atrial fibrillation to control the rate. Atrial fibrillation is also very interesting. It is difficult to restore the rhythm in these people. At least if you control the rate, these people have benefit. And in ventricular arrhythmias, again, which are more fatal, these drugs are useful. And I think we are coming to the conclusion of my talk. The key messages are as seen there. Beta blockers are used in patients with CAD to reduce harmful effects of excessive adrenergic activation. That is their main theme, or the main action is to decrease the adrenergic activation. There is a lot of evidence which I have shown in some of the trials and data that is available. Greater mortality reduction in CAD patients in the largest and longest real world evidences which we have seen. Effective reduction in resting heart rate and MACE in Asian patients, that is also from our counterparts we have shown. Improvement in LV ejection fraction and other cardiac functions and parameters in tenacity, that is the Indian study from Ahmedabad, and other studies as mentioned. So I think with this I conclude my talk. Thank you very much for your attention.
I think we'll have the final talk by Dr. Srinivas Rao. He's going to talk about role of beta blockers in heart failure. Keep your questions ready. You should be what you call focused, to the point, and don't make the question very long. Hey, I saw that, but they should write it.
Good evening to all of you. And we know the uncontrolled hypertension and patients who are not treated well with ischemic heart disease, they eventually develop heart failure, which is a very, very bad prognosticate disease. In fact, mortality with heart failure is much higher than most of the malignancies. The average lifespan after development heart failure without any comorbidities only about 5 years. And then if they have unfortunately other comorbidities like diabetes or renal dysfunction, the lifespan is further comes down. So prevention of heart failure is extremely important for us. And unfortunately, if any patient develops heart failure, we have to put all the guided treatments to these people, the 4 pillars namely. Maybe new options also coming for the treatment of heart failure, but the cornerstone of treatment of heart failure are these 4 pillars. Among these 4 pillars, the most important thing is the beta blockers. Let's go and see how beta blockers are going to help us. The 4 different kind of modalities by which we treat patients with heart failure, as we know, that the renin-angiotensin system, we are going to block that when it is heightened in activity, and also the non-preference or catecholamine surge, which is seen in heart failure, we are going to tackle with the beta blockers, which is very important for us. And of course, nitric peptide deficiency, which is in heart failure, we are also going to target with RNA molecule, and we have cardiometabolic pathways also by actually giving SGL inhibitors. When we have all these 4 pillars, the most important pillar that we have to think about is beta blockers in heart failure. What happens in heart failure? In heart failure, we find that there is a downregulation of beta-1 receptors in the heart. We have the various receptors are located in the heart. We all know from our pharmacological teaching and also from medical background that we know beta-1, beta-2, and also beta-3 also located in our body, and then alpha-1 receptors. They're all actually acted upon by the catecholamines. When they are increased in their circulation, that has got a bad effect on many of the vertebral hemodynamics, especially in the myocardium. Now, a normal heart, if you see the preponderance of beta-1 receptors, beta-2 receptors also located in myocardium, and it's not rare. Please remember the beta-2 receptor also located in the myocardium. What is the role of beta-1? It is, of course, the cardiac tonicity is increased, heart rate is increased with beta-1 receptors. But beta-2 receptors, the myocardium, when they are stimulated by heightened circulation of catecholamines, leads to a exuberance of noradrenaline in the myocardium, and then this myocardial content becomes more, and this leads to fibrosis and myocardial dysfunction. And of course, the alpha-1 receptors are not located in the myocardium, but they are in the periphery. They are activated by increased surge in the catecholamines during the time of heart failure. And an increase in alpha-1 activity leads to a vasoconstriction, and thereby leads to afterload increase, and therefore myocardium gets what we call much more damage in this. So there is increased preponderance of a beta-2 receptor activity in failing heart, and also alpha-1 activity in the failing heart. And this is how we represent a normal heart with preponderance of beta-1 receptors are there. When heart is failing, and there is a downregulation of beta-1 receptors and upregulation or increased preponderance of beta-2 receptors. Of course, in the periphery, we have alpha-1 receptors which are getting activated in heart failure. Now, when the heart failure actually exists in a patient, it is a real the hemodynamics are changed. In fact, we try to survive, the body tries to survive a insult to the heart. When the heart is not able to pump, it gets a kind of boost by increasing the catecholamines. Initially, there may be improving our survival, but for a long period of time, when they're existing with the heightened catecholamine activity, this is a kind of a damaging effect on the heart and also in the periphery. And this is how we say this catecholamine surge in acute heart failure, initially or the saving, it ultimately kills. Beta blockers, by actually stopping the activity of catecholamine surge in heart failure, and also helping in trying to regulate the beta 1 activity and beta 2 activity is likely to actually protect the system. Do we have any kind of data to say that beta blockers are going to help in failing heart? Yes, we have so much exuberance of what we call data that's available over the last 3 to 4 decades. In fact, over 18,637 patients are studied in a kind of what we call double-blind way, placebo-controlled way, and then they showed a consistent decrease in the mortality of the heart, of the myocardial death, or maybe all-cause mortality. In fact, about 30 to 35% decrease in mortality and all-cause mortality, cardiovascular mortality is seen in patients in various studies when you actually compile them together, and this is highly statistically significant. Apart from that, the combined risk of death and as well as hospitalization also comes down by almost like 25 to 30%, which also is an important factor in prevention of recurrent hospitalization. Please remember that when you prevent a hospitalization, a patient with heart failure, with what we call worsening of his symptoms, it means that patient is going to have a better prognosis. Every kind of hospitalization with the worsening of heart failure is going to have a exponential increase in the chances of death. So prevent a hospitalization in any drug in a patient with heart failure is extremely important in improving the prognosis. Now, in nutshell, if you see the number of studies we have landmark trials like with carvedilol and the US carvedilol program and Copernicus study. We have CIBIS study, which is again a landmark trial with bisoprolol. We got Merit Heart Failure trial, which is also a landmark trial. All of them have produced a statistically significant decrease in all-cause mortality, cardiovascular mortality, and hospitalization heart failure as well. But if you look at these different trials, they are actually conducted in different ways. In fact, the US carvedilol program is a mild heart failure. Copernicus was a severe heart failure. Many of the patients were at stage 4, class 4 patients in heart failure. And then if you see CIBIS trial, which of course included about 17% of the patients which are in class 4. In fact, this is includes high risk population, and many of the patients were in class 3. It was not included. The mild heart failure were not a part of this particular trial. It included about 13,000 and odd patients, and when the study was done with bisoprolol, it was concluded prematurely because it was thought unethical to continue the trial because of exuberance of benefit of this drug in these patients. And Merit Heart Failure trial included a milder form of heart failure patients, that is class 2 and class 3, majority of the class 2. So from this we know also the numbers to treat in a patient with beta blockers to not to produce one death in a year is about 15 patients in carvedilol, or about 23 patients in about bisoprolol or metoprolol, about 27. Although the numbers look different, but they are not really head-to-head comparison. It is just to show the kind of benefit you get with any of these beta blockers. And because the trial had inducted patients of different types, you cannot say that they are equivalent, they are actually comparable head-to-head. Now, is there a difference in case of beta blockers when you are giving heart failure patients with regards to age and sex as well? So Dr. Pramod and Dr. Nirmal were speaking about age as well as the factor which we have to consider in patients with either ischemic heart disease or hypertension. So also when we consider patients with heart failure, age should be, is there in the difference in the outcomes of the patients with regards to age? If you look at all these trials, the landmark trial, CIBIS, and then as well as US heart failure trial, ANZ, CIBIS 2, Merit Heart Failure trial, all of them compiled together, it looks that whether the patients are less than 50 years, more than 60 years, even senior citizens are more than 75 years, all of them receive the same kind of benefit. So do not ever keep away patients by not giving the beta blockers in patients with heart failure or hypertension if they are old enough. There is no patient who is old enough in not getting a beta blocker for the indication of heart failure, hypertension, or ischemic heart disease. Now, so also if you look at the gender, both male and females, they receive the same kind of benefit when they are exposed to beta blockers when they are having a heart failure. Now, another important thing is, what about ejection fraction? We are speaking of low ejection fraction, reduced ejection fraction patients, the mid-range ejection fraction, and preserved ejection fraction. What happens in these patients when you are trying to address this issue with beta blockers? Well, we know that the current, current studies what we have all shows the important, aspect of this is that patients who are exposed to beta blockers, whether it's metoprolol, whether it is metoprolol, bisoprolol, or for that matter, whether it is a carvedilol, when you look at what you call the ejection fractions, it's always a ejection fraction less than 40, which is statistically significant decrease in the outcomes. Whereas if you look at mid-range, although numerically there are less number of hospitalization and also the benefits which you see, but that is not statistically significant. Therefore, it is not as beneficial as we see in the less than 40% or reduced ejection fraction. And patients who have got more than 50% of ejection fraction, which is preserved ejection fraction, then the data shows they are not really beneficial in these patients. So we do not have any studies so far conducted, exclusively in these patients with ejection fraction more than 50. But whatever we gather from the past studies, we have a kind of a data to show that it is not beneficial to get more than 50%. So we are not focusing on only patients with heart failure with a reduced ejection fraction. So I just brought into only case of discussion to say if somebody has a projection, what do we do about it? Now, what happens in atrial fibrillation? We have also have many of the patients with heart failure have atrial fibrillation. Atrial fibrillation, comorbidity, what we see. And then it is not uncommon to see what happens if the patients are in atrial fibrillation. And then we have, the data that so far seen is the beta blockers, when they are given in patients' sinus rhythm, their benefit is very, very pronounced, but this benefit gets attenuated when the patient has atrial fibrillation. Well, we're going to speak a little bit about this a little later when we're speaking exclusively about the different class of beta blockers when you're talking. This is a compiled data from all the groups of beta blockers. Let's talk a little later about this aspect atrial fibrillation in the next few slides when you're taking up in the next few slides. Now the thing is the relationship between the dosage and the cardiovascular outcomes. Many times we see when we are giving the patients with heart failure, the dosage that we see is very minuscule. We start with 1.25 milligrams of bisoprolol, and then maybe 2.5, and then we just leave it like that. And please do not leave it like that, because we have to expose the patient as much as possible, highest possible dose which he can tolerate. Do we have any data to show that when we are trying to say the patient with heart failure, when we are giving this beta blockers, with regards to amount of dosage and outcomes, is there a data to show? Well, the data shows a very interesting features. But before we go to the next slide, I would like to call upon saying that the minimal dose or maximum dose of each of these drugs, that is bisoprolol with 1.25 and 10 milligrams is the highest dose that we give. In CYB2 trial, they tried to give a lowest dose to possible to patients to start with. They went escalation of the doses to almost like 10 milligrams, and the average dose was almost like 7.5 milligrams, because many of the people could tolerate the drug in spite of the fact they had a borderline blood pressures. So it is possible to escalate dosage in many of the patients. Carvedilol highest dose is 50 milligrams twice a day, and metoprolol succinate is 200 milligrams twice a day. In fact, it's very interesting to know that patients who are getting metoprolol, please remember, metoprolol has got different vertical metabolism, different in ethnic races. Even Indians also will see that different people have different kind of metabolic rate of metoprolol, and therefore, unlike bisoprolol, there is a lot of variation in the kind of the response to metoprolol in various patients. Some patients, when they're receiving 12.5 milligrams once a day, they have enough vertical decrease in the heart rates. Some people, they don't even drop the heart rates, even 100 milligrams BD. This is because of the inter-individual variation of metabolism, which involves the cytokine processing of metoprolol. Such kind of variation is not reported with bisoprolol, and therefore one must be very careful in trying to address this kind of inter-individual variation with metoprolol. Now, when you look at a RAFT study, which has produced very good information, saying that beta blockers, when they has been given a smaller dose or higher dose. For example, when you say smaller than higher dose, with each quartile, let's say patients are receiving 50% of the recommended dose or 100% of the, more than 50% of the recommended dose. Patients who are receiving less than 50% of the recommended dose compared to those people who have been getting a more than 50% recommended dose, there is a huge difference in the outcomes, which is statistically significant. So I just want to bring to everybody's notice that we should be giving highest amount of dose that the possible to the patient which he can tolerate. Don't just get satisfied with starting a small dose and keeping quiet. And then what about COPD? We have also another comorbidity with COPD. This is a very interesting slide, which is actually part of the WellHub study, which has shown the two groups of patients who are actually involved in the trial were those people who had no COPD and COPD. And those people who had no COPD, beta blockers versus no beta blockers, definitely the outcomes are much better with the beta blocker. Then what happens to those patients with COPD? Those patients who are in COPD inducted in this study, if they had beta blockers on, the mortality was much, much lesser, despite the fact they had COPD. This brings us to notice that patients who got COPD must not be excluded from getting the benefit of beta blockers. And then this is again the compiling of the various studies, which shows the analysis of all these studies shows, meta-analysis shows the beta blocker are beneficial in the presence of COPD and must be considered. While we are doing beta blockers in the patients with COPD, please remember that we have to balance out the beta stimulation and beta blocking as well, because beta stimulation is bronchodilators what we are giving. So consider a long-acting anti-muscarinic treatment than giving a beta agonist in these patients and trying to address the bronchoconstriction. And we balance out in trying to give the best of the treatment in these patients while doing no harm to the patients. Now, what happens when the patient has heart failure, unfortunately gets into admission to the hospital? There's a deterioration in his symptoms and his worsening heart failure is there, and he is in a beta blockers. Remember that we should not ever stop the beta blocker when he is getting hospitalized. You can get down, the dosage of beta blocker should be reduced to optimal level, but don't give him away totally from the beta blocker. We have this Optimus heart failure registry, which shows almost like close to about 7,000 patients were actually studied in this Optimus heart failure registry, which shows that at each quartile of the beta blocker dosage, which is maintained in these patients after hospitalization, there was incremental what we call benefit to these patients rather than a kind of harm to the patient. There is about 42% risk reduction in these patients when they are on beta blocker rather than completely off the beta blocker. So some amount of beta blockers in patients who get admitted with worsening heart failure is always welcome than totally taking it out. Remember, this is an important fact that we should remember when we are treating with patients with heart failure with worsening. So all beta blockers is same, is already addressed by Dr. Pramod, very nicely talked about it. Well, they're not all same. They have different kind of characteristics. Number one, they are beta selective, extremely beta selective. Some are partially beta selective. Some are non-selective. For example, propranolol is non-selective. So also carvedilol is non-selective again. And then we have what is called as the bisoprolol, which is highly selective for beta-1 receptors in comparison to beta-2 receptors. And of course, we have third generation beta blockers that nebulizer is highly selective for beta-1 receptors. Another thing, of course, this slide doesn't show is the lipophilicity or the hydrophilicity. Lipophilic beta blockers are likely to penetrate blood-brain barrier and likely to have a decrease in the modulation of sympathetic tones, and therefore they are likely to give a benefit of decrease in the sudden cardiac death. And those ones which are like hydrophilic may not have this kind of benefit. One of the important and popular hydrophilic beta blocker is atenolol. And of course, we also have labetalol also, which is hydrophilic and least lipophilic. And then, so also esmolol is hydrophilic. So maybe when we are choosing a patient with ischemic heart disease or ischemic background with heart failure, always choose a drug which protects them from sudden cardiac death. Now, bisoprolol in the treatment of the exclusive, if you talk about bisoprolol, let's see a few slides about this. See, CYBIS 2, CYBIS 1, CYBIS 2, CYBIS 3. Three trials were landmark trials. CYBIS 2 is a trial which I inducted, as I said, 1,300 patients, and its average duration was about 1.3 years, prematurely discontinued because you see that the primary endpoint was all-cause mortality, which was highly statistically significant, 34% decrease in the mortality. And it was so exuberant that to stop this trial from further vertical prolonging because it was unethical. Then the exploratory composites also were very interesting because there is a statistically significant 46% decrease in sudden cardiac death in the patients, which also are important. Apart from that, of course, the myocardial infarction and all-cause hospitalization of heart failure also were statistically significantly decreased in these patients. And the modes of that, if you see, why I'm talking about sudden cardiac death is one of the important ways the patient dies in patient with heart failure is sudden cardiac death. And if you look at the New York Heart Association class 2 and 3 and 4, patients who got class 2 symptoms or class 2 or maybe class 3. Class 2 means hardly a very minor degree of symptoms, minor degree of decompensation. Do not forget that these are the patients who got highest amount of incidence of sudden cardiac death. Almost 64% of them have sudden cardiac death. Similarly, if you have patients with New York Heart Association class 3, they have 59% decrease incidence of sudden cardiac death. In class 4, of course, it comes down. So just because the patient has got minor symptoms, it doesn't mean that they don't have peril of sudden cardiac death. So any drug which decreases this sudden cardiac death, for example, bisoprolol, which has shown a 46% decrease in the mortality in sudden cardiac death, is really a good drug to actually prevent sudden cardiac death in patients with heart failure. Now, other thing that we see about alpha activity and beta activity, we know that carvedilol has produced a wonderful results in the landmark trials of both US carvedilol study and as well as Copernicus study. Copernicus was a study where severe heart failure was actually studied with carvedilol. But unfortunately, although it's produced excellent results in reduction in the mortality, even in the severe form of heart failures, the ability to tolerate this carvedilol in patient with heart failure is very, very poor. In fact, because of alpha blocking activity, it causes a vasodilatation, which may be important fact in heart failure patients, but most patients who have heart failure, they have a borderline blood pressures. And this borderline blood pressures, when they are giving carvedilol, it poorly tolerated. So that's where if you actually substitute this carvedilol with, when you actually substitute with this carvedilol with bisoprolol has got a lesser form of our products, producing any lowering of blood pressure, dizziness and hypertension comes down, and they can tolerate this drug much better, and you can also reach a higher doses with bisoprolol, and then at the same time, when you are following them up over a period of 6 months, you can also see the improvement in New York Heart Association class as well. In fact, many of the patients, they go into better lowering of the class from class 4 to 3 or 3 to 2 or class 1 as well. So it is possible to give this drug in much sicker patients when the blood pressure is borderline or low. And you can reach a higher doses, getting a benefit of higher dose of beta blocker in patients with heart failure when you substitute bisoprolol in the place of carvedilol. Now, when you combine ARNI and this bisoprolol, again, in the patient post-MI patient who have got LV dysfunction, there's a kind of a very good effect in prevention of remodeling and also the outcomes of reduction in the hospitalization, mortality, and as well as recurrent myocardial events, myocardial ischemic events also comes down to a large extent. Now, let's just look it into each of these, comorbid that what we see. In Indians, we say that about 50% of the patients who have got heart failure have got diabetes, and it is a very important comorbidity. In fact, about 35% of the patients, they got atrial fibrillation. COPD is common. It can range anywhere between 10 to 40%, and renal failure also is one of the major factor that actually, plays a negative role in the patients who got heart failure. And it also is very common to see, especially in the population, about 20 to 70% of the patients can have the CKD in these patients. Now, when we have a patients with atrial fibrillation, I was talking in the previous slide, patients who got sinus rhythm, they got excellent vertical outcome. Patients who got atrial fibrillation, the studies have not been proven so far to show a benefit of beta blockers in patients with heart failure, unlike patients who have got sinus rhythm. But if you look at patients with bisoprolol and carvedilol, when you compare, there is a study which actually shown that there is a benefit that patients receive with the bisoprolol compared to carvedilol, and therefore in patients with atrial fibrillation, the added advantage of having some kind of benefit in these patients compared to the carvedilol. Apart from that, the chances they can go into what we call sinus rhythm with bisoprolol are much better than carvedilol. In fact, even if you're attempting what we call a chemical as well as what we call electrical cardioversion, the chances of they getting into sinus rhythm is much better when bisoprolol is given compared to carvedilol. And again, patients with diabetes, if you have diabetes, an important risk factor for worsening of the prognosis in heart failure patients. Patients who got heart failure and diabetes, their average lifespan is not even 5 years. In fact, 50% die in 5 years in patients with as such in heart failure. If they have diabetes, it's not even 30 to 40% of the patients almost fail to reach 5 years. So when we have diabetes, a problem of beta blockers is dysglycemia, and this dysglycemia is more pronounced in non-selective beta blockers. The more selectivity of the beta blockers, the better it is. In fact, patients who are on diabetes, many of the physicians, they tend to actually take away the beta blocker, thinking that it produces dysglycemia and worsening of the control of sugars. But if a patient in heart failure receives a highest amount of protection from cardiovascular death, it is diabetic patients who receive the best what we call relief from cardiac death or all-cause mortality. In fact, diabetics receive much better water protection. And so also we know that bisoprolol actually has less amount of what we call dysglycemia compared to other beta blockers, being very high cardiac selectivity, and it has got the best of what we call protection in terms of giving them a better what we call outcomes, especially even if the dosing is almost like highest form of dose of bisoprolol. Now, this again is saying that COPD is another important comorbidity, as I already talked about, that beta blockers should not be refrained from giving. By virtue of fact that bisoprolol has got a very high selectivity, it is likely to produce less amount of bronchoconstriction or bronchial overreactivity. Therefore, this is likely to be a very good molecule to be used them. And we compare to carvedilol, which is non-selective, bisoprolol has got a better what we call better ability to tolerate in patients with COPD patients. Now, other important thing is the renal dysfunction. When renal dysfunction gets in, the one beta blocker which should not be given is atenolol. Atenolol is excreted primarily because of the renal route. We should never be giving any patient with whatever may be the indication for him atenolol. In fact, it should immediately stopped. But although metoprolol is not is excreted the kidney, but it is when you are trying to see patient with dialysis, in dialysis the metoprolol gets dialyzed. So all atenolols get dialyzed, estripitalol gets dialyzed, whereas bisoprolol doesn't get a dialysis, very minimal amount of it is dialyzed. So the ability to maintain a constant plasma levels in patients with receiving regular dialysis in patients with renal dysfunction is very much possible with bisoprolol, and bisoprolol should be a choice in this kind of patients. In fact, if you compare the carvedilol and as well as the bisoprolol, in patients undergoing hemodialysis, all-cause death and as well as MACE comes down significantly with bisoprolol compared to carvedilol. And therefore, bisoprolol is a low dialysable beta blocker. It maintains its concentration even though they are undergoing dialysis regularly, and it has got a balanced excretion between hepatic and renal, and then even if one of them is actually dysfunctional, you still do not have problem with its plasma levels, and therefore safely can be given. And food doesn't get interfered with the bisoprolol intake, and therefore there is no much first pass at metabolism with this, so plasma levels are attained very quickly with this particular drug. And therefore, bisoprolol appears to be a preferred molecule in heart failure patients. In patients who have got COPD, atrial fibrillation, stage 4, renal dysfunction with hemodialysis, switching carvedilol to bisoprolol has got a benefit in these patients, and we can actually achieve a better dosing in these patients without having much adverse effects of this beta blocker. So, the take-home message for my particular presentation is that beta blockers are cornerstone for heart failure treatment. Never withhold beta blockers unless there is a real contraindication, because they have got best what you call protection against progression of heart failure, or for that matter cardiovascular death, almost 30% decrease in the cardiovascular mortality. Bisoprolol has proven efficacy in landmark SciBase trials, and has shown with more advantages in giving this drug in particularly we have comorbidities like COPD, atrial fibrillation, or stage 5 patients with CKD with hemodialysis. And then switching from carvedilol to bisoprolol can be a better thing, because it is better tolerated in patients with lower blood pressures, and then it is a better tolerated even in the patients with COPD as well. And after this, I just want to take one couple of minutes, because I just want to project 2 slides which are of very interest. A lot of interest is being generated, a thought-provoking also. Recently, there was a paper which actually published saying that patients who have got heart failure, they have got autoantibodies to beta-1 receptors. These autoantibodies are likely to cause deterioration in the function of the heart, and this when you can sequester this autoantibodies by immunoabsorption or some other means, you probably can have a better outcomes in patients with heart failure, or those patients who have got heart failure at the beginning of their continuum. If we can sequester these autoantibodies, probably we can prevent progression of heart failure into a higher form of or worse form of heart failure. So this is how the autoantibodies are located in the body in many of the patients who got heart failure, and then either immunoabsorption or a aptamer mediated neutralization of these antibodies perhaps may be one of the futures that we see in coming years in treatment of heart failure. And one word about another receptor which we often forget is beta-3 receptors. Beta-3 receptors are located in the detrusor muscle of the bladder, gallbladder. It's also located in pancreas, located in in the endothelium. It's also located in myocardium as well. When you stimulate these beta receptors, if there's agonism, when any agent is causing a kind of receptor stimulation of beta-3, it is beneficial in the form of relaxation of the myocardium. It prevents apoptosis, and also it is better what you call contractility. The myocardium also is known to be there, and it is going to be protective. In fact, it's also known to release more nitric oxide in the endothelium as well. And bitoprolol and nebivolol are known to increase the beta-3 expression in myocardium and also endothelium, and increases what we call the better outcomes in patients, perhaps better outcomes in patient heart failure. Whether the carvedilol reduces or not beta-3 activity is not very known, but at least in one of the studies is shown that carvedilol reduces the beta-3 activity, which may be probably deleterious. This is only what to call a thought-provoking points. It is nothing what there is no double-blind study which has shown about it. But to actually know further the role of beta-3 against the treatment of heart failure, the 2 trials are actually ongoing. One is beta heart failure trial. Another is a trial which is efficacy of mirabegron, which is normally given for patients who got overactive bladder. And this is also being tried, because mirabegron actually directly stimulated beta 3 receptors. It is not unique to the only tetrasomal muscle in the bladder, but it could be generalized. So we still have to wait for this kind of beta 3 agonism and what happens in heart failure. It will be future that we need to see. And thank you very much for your patient hearing.
Do you still have patience to ask questions? Or do you think it is a bit late? No, I think we will have questions and answers for about 10 minutes at least, and then first can I have the questions if at all there are any? Do you have any questions?
Yeah, we'll discuss it.
No, I have written down some questions. So.
To get the ball rolling, sir, I would like to ask Pramod. Pramod, what do you feel about? Pramod actually was very nice lecture he has given, very thought-provoking and very lucid trial, a very lucid talk he has given. He was actually, Dr. Pramod, you was saying that we should be giving in the ACS patients the beta blockers, right? I mean, the beta blockers, right? And recently, if you stop AMI, if you see the trial presented in ACC 2024, they said patients who have been given beta blockers post AMI, if they didn't have early dysfunction, it didn't matter. Your comment?
Yeah, I think previously we were having evidence that we have to continue beta blockers after myocardial infarction up to at least 3 years. Subsequently, some data came from registries which said that up to 2 years you continue beta blockers and then you can discontinue. Now the recent reduce AMI trial is there, which has looked specifically whether it is beneficial to continue beta blockers and how long. What they have found is if the patient has got LV dysfunction and then subsequently it improves, beyond 1 year continuation of beta blocker group did not have any benefit. So the idea now is all patients definitely should be given beta blockers, and anyway those patients we monitor. If the patient's ejection fraction is improving, then you can discontinue beta blocker after 1 year. I think that is my understanding of the data. But if the patient has got a reduced ejection fraction or is going to failure, then indefinitely you have to continue beta blockers.
And incomplete revascularization also. The patient has an incomplete revascularization also, you can continue the beta blockers.
So the data shows that if the patient post-MI has LV dysfunction, there is definite indication. With no LV dysfunction, if he is revascularized, then no role of beta blocker. If revascularized, that study had patients post-MI, primary angioplasty was done.
It's a very interesting question from one of the audience. Is there an escape phenomena from the beta blockers on long-term usage? What he's trying to ask is, at the end of 3 years, 4 years, is the effect of beta blockers wanes away or
No.
continues?
No.
So that's the what it is.
Because when you see patients with chronic beta blockade, one of the surrogate indicators for efficacy of beta blockers is a heart rate.
Yeah.
So if the patient continues to have bradycardia, that itself shows that the patient is chronically beta blocked. So there is no escape phenomena for beta blockers unless you abruptly discontinue the beta blockers. Then the benefit will escape.
The other question what I have for you is, in people who have been using beta blockers, there has been a decreased incidence of vascular events. Is there any specific study to show that long-term usage of beta blocker reduces the incidence of dissecting aneurysm of aorta?
There is no double-blind study, but at least patients who have got a dissection, a previous history of dissecting aneurysm, who have been operated, or patients who have got a minor dissections who have been given beta blockers, and also any of the class of DVAC is classification of dissection. When they are given beta blockers, it is known, it has been proven without doubt that the incidence of dissections comes down subsequently, because when your dP by dt is the one which actually is responsible for dissection. dP by dt is rate of rise of pressure. The rate of rise of pressures in the left ventricular myocardium, if you decrease the expansion, elastic expansion of the aorta comes down, and this is protective for those patients who got propensity to develop dissection.
No, I'm not disputing the role of beta blockers in preventing further occurrences of already dissected patient. I am trying to ask whether there is any data that people who are taking long-term beta blockers, there is a markedly decreased incidence of primary dissecting aneurysm of aorta.
I have no idea about
Yeah.
that. Then yes,
Because every study what we have seen,
it's after.
yeah, after, this is basically, for example, the guy, that Methodist hospital guy, what is his name? Surgeon? DeBakey. Michael DeBakey. He did a lot of work on dissection, and he had a dissection at the age of 85, 86, and then died of it. I'm not sure whether what drugs he was taking or other things.
So one thing is that when you see the patients who are got stiff aortas, they are the ones who are likely to have dissection. And when you have stiff aorta, the pulse pressure increases in them. In fact, systole goes up and diastole comes down. And this is where perfect milieu for developing dissection. If you give beta blockers, actually the systole comes down, diastole increases. So this pulse pressure can be decreased. This could be one of those mechanism. I mean, this could be one of those one of the surrogate markers that they will probably have lesser dissection.
I have one question. If the patient has got congestive heart failure recovered, and then his systolic blood pressure is 90, he is only on diuretics and other incidental medication. If you have to start the beta blockers, which beta blocker would be your first choice? Systolic blood pressure is only 86 to 90.
First of all, blood pressure, is not a thing which can you take it universally, because each individual have his own normal blood pressure. Many patients who have got normal persons, although in our OP we see when they're coming, especially young individuals and all, especially women, they have 90, 95 systolic blood pressure, and they are doing very well everything they are in the life they are able to do. They can swim, they can run, they can do all the sports activities. So when a person comes with 90 systolic blood pressure or so, look at him whether how is hemodynamics. First of all, does he have postural drop? Number two, does he have any kind of dizziness? Does he have cold clammy skin? Is the urine output normal or not?
No, he is well compensated. There is no postural drop.
Yeah.
And he is,
If
heart
suppose,
failure is
yeah.
under control. He is about 58.
Yeah, if the patient, why was he not taking, he has not been given a beta blocker.
Yeah, because that the treating doctor felt it might drop the blood pressure.
So I think
Further-
in these patients, you can still start a small dose of beta blocker.
No, which beta blocker?
Obviously, bisoprolol we can start a small dose, 1.25. That's been available in the smallest form.
No,
Or
wha-
you can also start, for example, there are some beta blockers. See, when we are giving heart failure patients with low pressures, there is one important rule of thumb they have given us. That is, if you have to give a beta blocker, do give them, but in a very minuscule way. For example, the drug that you can give very little dose is metoprolol. Start with the metoprolol, because we do not have injectable form of bisoprolol. We have injectable form of metoprolol. So take the injection and give them what you call 3.125 milligrams on the incremental doses. When you give, it is very surprising that many of them they don't drop blood pressure, but rather blood pressure improves in them.
No, the problem here
So,
is
I am coming to
Yeah,
that point.
yeah.
And so you have to try with the smallest possible beta blocker, smaller beta dosage, and arrive at what you call an optimal dose he is actually able to tolerate. So small dose of any of these beta blockers you can give. Avoid something like a carvedilol which has got a alpha action.
Okay, now the problem with bisoprolol is it is effective, but the duration of action is long. So should you get an adverse effect, you have to sit with the patient for the next 24 hours. This has happened.
Yeah.
That is the reason why I think when you're choosing a beta blocker for heart failure initiation, actually there is that drug is not available, unfortunately. It's called esmolol. Esmolol. Esmolol intravenous.
Available.
No, no.
It's
You give Esmolol
injectable.
intravenous.
Injectable though.
Yeah, injectable. Esmolol intravenous injection, and then see how the patient tolerates it. If the patient tolerates it, then you go ahead and then choose the drug of your choice. But there are a lot of advantages of bisoprolol. There is no denial about it. That is long-acting, it is cardioselective, it is metabolized by both liver and kidney. There are a lot of advantages and non-dialyzable. But then, one of the disadvantages is it is a long duration of action, and should there be an adverse event, then we are going to have a long stay with the patient.
That is the reason, sir, why I'm saying the rule of thumb is start with some drug, low metoprolol, which has got a shorter action, not tartarate, not succinate, and injectable form. And then your injectable form, you're not injecting. They take that particular liquid in 3.15 milligrams, something like that, put him in orange juice and give them. Slowly increase it and see how it goes. And once he tolerates this drug, probably can switch to bisoprolol with a long-acting later on.
One of the therapeutic dilemmas what you see in heart failure therapy is, if you see scientifically, both the ARNI as well as beta blockers have got the same hemodynamic effect in the long run, in the sense that both of them tend to improve the ejection fraction. Both of them have got a favorable ventricular remodeling, and there is a decrease in the sudden cardiac death, both with ARNI as well as with beta blockers. So if you have to choose one, which one will you choose?
It in acute setting or in a chronic
No,
setting?
no, no. This is patient had a MI, recovered, he is on follow-up, he is in congestive heart failure. Heart failure is well under control.
No, the thing of how did you have controlling heart failure? What
Sorry?
drug was it? I mean, you said heart failure is a control. What did
No, no,
which
heart
drug
failure
has
is
they
under
produced control?
No, no, I'll tell you. Heart failure is under control by the diuretics.
Acha, he is now hemodynamically stabilized with with that.
Yes.
So he is about to get discharged. He's not getting IV diuretics now, not getting any kind of inotropes.
Yeah.
Now the first thing that we should see between ARNI and beta blocker is what we see from the SIBIS 3 trial. SIBIS 3 trial. SIBIS 3 trial has compared ACE inhibitors or ARB with that of a beta blocker, where they have shown that if you choose a drug, number one, if the patient is dry and if he is not congested, you can go ahead and give a beta blocker. And if he is congested, on the contrary, not properly decongested, give ACE inhibitor ARB or ARNI, number one. Now, when you look at the outcomes in these two particular group of patients, first given beta blocker, the other group has been given ACE inhibitor ARB. Both had a equal amount of what we call outcomes, good outcomes. But one thing that has been shown a different is in SIBIS-3, the sudden cardiac death came down in bisoprolol drug compared to the ACE inhibitor ARB. So I think if the patient is well congested and dry and all, try to give beta blocker because that's going to give him a protection of sudden cardiac death, unlike that of a ACE inhibitor ARB or ARNI. And if he is on contrary, is not dry, is congested still, go ahead and give ACE inhibitor ARB ARNI.
I think there are different phenotypes are now demonstrated in heart failure. So they divide the phenotypes depending on the blood pressure, the heart rate, and other variables. So in the question here, one of the phenotypes is if the patient may have a high heart rate and a normal blood pressure. So in that situation, you can go with a beta blocker first. But if the patient's heart rate is low and his blood pressure is acceptable, then I think you can go with the ARNI. I think ARNI definitely has shown extraordinary benefit. And the SIBIS trial is an old trial that was only AC inhibitor. But now the ARNI is much more potent in comparison to AC inhibitor. It was shown.
No, there is one trial, post-MI. ARNI is no better than ACE inhibitor. So basically,
that Paradise.
Paradise trial. So the problem here is, there are too many options. So one of the recommendations is when you are starting a beta blocker, just to protect the patient against possible precipitation of heart failure, you also give SGLT2 inhibitor along with it, so that he is protected against possible decompensation induced by the beta blockers. So he is stable, and beta blockers If you see the not Milton Packard, John McMurray's article, he says, his standard treatment is he starts with beta blocker. Patient has to be dry, start with beta blockers, add what do you call SGLT2 inhibitor. Then you titrate the other drugs. That is the thing. But I'm sure there are very many other ways.
Those two schools of thought are there,
Yeah,
sir, in the sequencing of the 4 pillars of the therapy for heart
sure,
failure.
sure.
One is beta blocker first, and the other is ARNI first.
No, but
SGLT2 can be started immediately.
Immediately,
There is no problem with SGLT2.
it's absolutely safe. Absolutely safe. There is no dose titration. There is only 10 mg. Only one dose. But it is very important to understand and to implement that all 4 drugs have to be started as soon as possible. Even with a minimal dose, the benefit is much more as compared to those who are not receiving the drug. So that's very important.
With regards to this sudden cardiac death, protection, beta blockers have got 46, almost the tune of 46%. But if you look at the way, mode of death in Paradigm Heart Failure trial, if you look at all kinds of death they had, it's only about 6.8% decrease in the sudden cardiac
Speak
death.
into the mic. Speak it.
The thing is, when we are looking at heart failure patients, the sudden cardiac death is one of the important facts that we should remember. Drug has to protect them against sudden cardiac death. In fact, the Paradigm Heart Failure trial has shown a decrease in the sudden cardiac death, no doubt about it. But if you look at the magnitude of protection against sudden cardiac death with the beta blockers, it is huge. In 46% of sudden cardiac death decrease in the SIBIS trial. Whereas if you look at Paradigm Heart Failure trial, if you look at all kinds of modes of death, if you look at different kind of modes of death the patient had, if you look at that, the protection against sudden cardiac death only about 6.8%. So look at with 46%, look at what 6.4%, 6.8%. So no doubt beta blockers will have greater potency of decrease in sudden cardiac death than any of these class of drugs. That's one thing. If you look at the amount of decrease in the all-cause mortality and also the cardiovascular mortality, it is tune of 35% the data with all the kind of beta blockers. Whereas if you look at what you call ACE inhibitors or ARBs, is 14 to 18% only. And then ARNI is about a little bit more than what ACE inhibitors and ARBs. In fact, it comes to about 20% extra what you gain from the ACE inhibitors in those trials. So beta blockers, no doubt, is cornerstone in preventing cardiovascular death, progression of heart failure, and third thing is prevention, mostly the prevention of sudden cardiac death.
Yeah. For the paucity of time, I think I will go with the next question. Is gradual tapering of beta blocker mandatory for all types of beta blockers? If yes, what is the pattern to taper the dose? You want to answer or?
Both of you.
Nirmal, you want to answer?
Yeah, what is the tapering? Do you have to taper all beta blockers before you stop it? Or the pattern of tapering?
But why you want a tapering of the beta blockers if the patient is tolerating the beta blockers very well?
Suppose in case, as we discussed.
Yeah, that's how. If the patient want to taper, if the patient is a symptomatic bradycardia or there is a patient is developing in ECG the heart block, long PR interval or 2:1 high grade heart block, or the patient is not tolerating, patient is developing a lot of weakness and symptoms, then you can reduce the dose. Don't taper, reduce the dose, and slowly you can reduce the dose whatever the patient can tolerate the dose. Otherwise, there is no way of this tapering the dose or something. You can reduce the dose. Slowly you can reduce it till the tolerable limit.
I think halving of the dose is one of the things. There are no specific guidelines on how to taper, but general way of doing it is generally we try to half the dose and then monitor maybe subsequently after 1 week or so again go further.
No, one of the reasons why we should stepwise decrease the dosage of beta blocker is if you stop it abruptly, there's an increase in the death and increase in the events, cardiovascular events. This is the one actually, one that is we're mortally afraid of. Patient, you have sent him home on drugs. For example, let us say bisoprolol 5 mg once daily. Now he comes back with the heart failure, worsening heart failure. So what do? Should we stop the drug, and or should we reduce the dosage and then keep it? I think the answer is, if the patient can tolerate it, reduce the dosage and then continue it. Because if you stop the drug, it has been shown time and again that there will be an increase in the cardiovascular events, including sudden death. This has been well documented. That is the reason why you should not stop some of the drugs abruptly. Yeah. I think what is the time now?
Same question is, the patient with the sinus bradycardia, heart rate is approximately 50 minutes. Do we taper or stop drug abruptly? Already sir has given the answers.
The main reason for the beta blocker was not there as a primary antihypertensive monotherapy. It was not in the guidelines. The main reason for that was like beta blocker don't control the central aortic pressure. So what is the take on that? European guidelines.
Sir, in 2023, the European Society of Hypertension, they are included in the guidelines of the main hypertensive therapies. Now the drug like atenolol, because why this was not included? Because the drug like atenolol, which has a short half-life, almost 6 hours, and there is no effect on the early morning surge in the blood pressure. So there is a risk, I am coming to, there is an increased risk of a stroke with the atenolol. That's why the beta blocker was out of the thing. But the drug like a bisoprolol, which also work on the central aortic pressure. So these kind of beta blockers you can add. And same time, whatever we have discussed, the Indian patients are having a high heart rate, is more than 80. So any patient with the hypertension more than 80, you just first try to do the tell them to go for exercise, yoga, pranayama, because this exercise also reduces the heart rate, but still the heart rate is high, more than 80. This is now considering the predictor of adverse cardiovascular event. In those case patients, you can add the beta blocker to this patient as a combination therapy.
With your permission, sir, can I make a comment here on the hypertension?
I think one of the things about central aortic pressure, no trial has been done with central aortic pressure as the end point. What we have been doing it in all the trials is the measured blood pressure either at home or in the hospital by the healthcare provider, and that has been our end point of achieving or titrating the drugs. So far, there is no trial saying that this central aortic pressure is very important. The only one trial was that was done, and that is the one that triggered the whole thing, was CAFE study, conduit artery function evaluation, using perindopril and calcium channel blockers. So that trial has shown that drugs that improve the conduit function of the major arteries have got a better vascular outcome as compared to other drugs that do not decrease it. But that is the only trial so far as I'm aware of it, where the conduit function has been evaluated and that has been the end point. But I'm not aware of any recent trials where they have used the conduit function nor used the central aortic pressure as the end point for titrating the drugs.
One aspect about blood pressure and beta blockers is, beta blockers do not act uniformly in all the population. In fact, it is the best drug to be used in the younger population, less than 50 years, because they are hyperanemic. Beta blocker primarily work as antihypertensive drugs because they decrease the renin synthesis. If person has got low renin circulation in hypertension, they do not actually respond. So that is one of the reasons why beta blockers have been very unpopular. If you try to give these beta blockers to older population, generally they don't respond most of the time. And they have beautiful respond with vasodilators or diuretics because they are hyporenemic.
Therapy at
Loudly.
130 by 80 millimeter in our Indian population, still I say no. Because even if the blood pressure is 130 by 80, better lifestyle management is better. And then if it's persistently above 140 by 90, only then you can start the medication.
Your end point for hypertension is 130 by 80. So how can you start treatment?
how frequently is 24-hour BP monitoring done in routine practice? Very rare. But ABPM,
No, ABPB, ambulatory blood pressure, nowadays, we are forced to make a diagnosis because they come, say, sir, I have measured my blood pressure in the house. It is one day it is 160, other day it is only 150. Should I start the tablet or not? First of all, the guy does not know how to take the blood pressure by himself. So he should be taught how to take the blood pressure and what are the conditions to be fulfilled. Second thing is, now how do you, what do you call, software where guy comes and then says, you please tell me whether I have to take a drug or not take a drug. I said, you first have a, ambulatory blood pressure for 24 hours. And that will give you whether you are hypertensive or non-hypertensive. That too only for that day. So basically, if your cutoff points for ambulatory blood pressure normals, hospital setting normals, and home blood pressure things are all different. So if the values are more than 140/90, certainly I think you need to tell him he needs to take a drug. The reason why it is important is once you start the drug, it is forever. You are going to do a lot of damage if you don't diagnose it properly. That is the reason why ambulatory blood pressure, we are doing, at least most of my colleagues in our institutions, we are doing it 1 to 2 per week, every one of us.
In fact, sir, most of the physicians are not doing it. I don't know how many physicians are taking it up. We as a cardiologist, we are doing not with the number of times we should do it, because it comes to existence when they have a doubt of hypertension, because the patient, the doubt that because we have seen the blood pressure now at home, he says that his blood pressure normal, number one, but there's a doubt of diagnosis of hypertension. Second thing is, if you have a patient who apparently looks blood pressure is under control, but he has end organ damage, this creatinine is going up, and then his LVH is not regressing over a period of time, then we need to know whether he has got all the throughout 24 hours blood pressure control or not. And the most important thing which is emerging into one of the therapeutic dilemma is the nocturnal hypertension. Many of the patients who have got nocturnal hypertension have the worst prognosis. So especially diabetic population, they have nocturnal hypertension. So unless until we do 24 hours BP monitoring, we will not unearth the problem of nocturnal hypertension or non-dipping also. Even if it may not have hypertension, but even if it doesn't dip, it is going to be deleterious to him. So we have to establish fact that the patient is dipping or not. So these are all important things about 24 hours ambulatory BP monitoring, but it is not come into same kind of popularity as come with the cardiologists. In fact, people have to take up this 24 hours BP monitoring much more often. Isolate, yeah, you want to answer this?
what is it?
Isolated diastolic blood pressure.
Role of beta blockers in the isolated diastolic hypertension.
Beta blocker. See, the beta blocker, you should start the beta blocker as an antihypertensive drug only when there is a compelling evidence, compelling indications are there, like a coronary artery disease, heart failure, atrial fibrillation. Isolated diastolic hypertension, especially the young age patient, you can use the calcium channel blockers, ACE inhibitors and ARBs, they're better than the beta. Only beta blocker, whatever the new guidelines is saying, is compelling indication, or any young patients who is having a high heart rate, more than 80, then you can go. Otherwise, not required. One last question: when to use a bisoprolol plus telmisartan versus bisoprolol plus amlodipine? Bisoprolol telmisartan, you can use all the indication as a hypertensive in the hypertension patient, except the patient who has a chronic kidney disease stage 4, or the patient has a hyperkalemia, or the patient who is intolerant to telmisartan. Amlodipine you can add, it is a good drug, especially in the coronary artery disease when there is a patient has a recurrent angina, because it has anti-anginal effects, number one thing. In kidney disease also, chronic where the telmisartan you cannot use, you can use the amlodipine. Amlodipine plus bisoprolol is a good combination.
This isolated blood pressure, the entity actually is seen in patients who have metabolic syndrome. First treat the metabolic syndrome, then it gets automatically corrected.
see in young people isolated diastolic, isolated systolic in elderly. Both are difficult to treat.
Thank you, sir. It was very insightful session, and we have a great audience offline and online as well. So we have today with us our South Cluster Head Raghavan to give his closing remarks.
Thanks a lot, doctors, for your patience, because it's more than 2 hours this meeting has gone. Big thanks. We could start on time, and we could really thanks to Dr. Pramod for pushing us, and Dr. Dayasagar Rao was also particular that we should start by 8. And if we had not started, it was still further gone late. Big thanks to Dr. Dayasagar Rao for helping us out as a chairperson, Dr. Srinivas Rao for helping us out in heart failure, Dr. Pramod for helping us out in CAD IHT sessions, and Dr. Nirmal Kumar for excellent presentation in hypertension. And only thing, sir, I have traveled with Concur right from the start when the sales was 0. I launched Concur in India in '93. And now I feel proud that Concur is the #1 prescribed beta blocker among various beta blockers. Only thing, when Concur was launched, it was priced at 14 rupees per tablet, where atenolol was available for 50 paise. And it had only one indication, hypertension, till 2000. And only when the CBIS-2 trials came, bisoprolol was more used in heart failure. 2002, we reduced the price of Concur to 4 rupees. And still we could not compete with atenolol. And atenolol, fortunately or unfortunately, pushed all the beta blockers out of hypertension. And our only indication which was left was heart failure. By the time metoprolol took over, and metoprolol replaced atenolol in CAD and IHT. That is the reason metoprolol is still the #1 prescribed in India. But globally, if you see, bisoprolol is far well prescribed than metoprolol in IHT and CAD also. And this 2004 or 5 only, we got the approval for IHT and CAD. And then we were left out only with 2 indication. But thanks to ESE and ESH, now resurgence of beta blockers have happened. We can make bisoprolol as the first line choice, and Concur can become an armamentarium usage of hypertension also. That is the very reason we have come out with fixed dose combination, because fixed dose combination is level grade A evidence in management of hypertension now. So we were handicapped with only Concur AM and low dose with small dose of a diuretic earlier. But now we have got Concur T, which will invite a lot of patient support. So big thanks to you, doctors, for your patience. We'll join for fellowship and dinner. Thanks a lot, doctors.